G'day.
Hello.
Welcome everyone. My name's Nccn Guidelines. I'm a GP family physician in Tamworth in New South Wales, and I suffer with ocular melanoma. I developed it about 5 years ago. Welcome everyone. And I've got Kate and Anthony with me here online. We're having a few technical difficulties getting some of our other panel members online, but they will be here quite shortly. A little bit about my story. Look, I've had a nevus for ages, and suddenly I started noticing visual distortion about 7 years ago or so. And at that stage, it was a series of monitoring, seeing if it was growing, and then after some time deciding to have plaque therapy, which I had to travel down to Melbourne for, as is often the case across Australia and New Zealand. You do end up having to travel around the country to see different specialists and have treatment. Since that time, I've been followed up by my ocular oncologist in Sydney. I've seen Anthony once as a patient just to get some advice around surveillance. But other than that, life for me has been pretty normal. I suppose the advantage about having medical knowledge is sometimes you can know a little bit too much. Other times you can, I suppose, work through the statistics that all of us are facing and try and sort things out. I certainly advocate very much for all my patients who have a rare disease, such as ocular melanoma, to reach out on social media. One thing about rare diseases is there's often a fair few people around the world, and with it, and often it's a good way of creating discussion. I'm a fairly active member of the North American group and certainly the Australian group. Might hand over to Kate, and Kate, maybe you could tell a bit of your story. And certainly at this point in time, I'd like to invite anyone out there to, on this last panel session of the conference, to post some questions on the chat session, and we'll be happy to try and answer them. Kate.
Thanks, Ian. I won't go into too much detail. I'm a patient advocate, I guess. I found out a couple of months ago that a melanoma I've been dealing with for 30 years had grown quite substantially, and so it needed to be removed. So within 3 or 4 weeks of getting that information, we had removed the eye, and I got my new prosthetic a couple of weeks ago, so I'm still getting used to it. But I survived at the water park yesterday, so all is going well. And Professor Joshua is my contact and my expert here in Sydney, so I'm very lucky that I live in the city and it's not as much hard work, I'm sure, as it is trying to travel from regional areas. So I've just told my story on the last session, but if anyone has any questions at all, please, just shout in the chat.
And of course, I think everyone knows Professor Joshua, who's been in and out of the conference, I think, most of the weekend, providing very helpful and useful information and advice. Anthony, look, I'm a regional rural patient, and also Kate, you might like to comment about the issue about transport. Australia's a large country, we're spread out. Are you happy doing things like telehealth and those sort of modalities? How hard is it for rural patients to access you?
Sorry, is that for Anthony?
So we're doing a lot of telehealth. I'm happy to answer my perspective, and then Kate, and then I'll hand it over to you. So we're doing a lot of telehealth now, and we do even trials over telehealth. So partly because of COVID, the government changed some of the Medicare rules about telehealth. And so all of a sudden, it became much easier to do telehealth consultations. I was always happy to do them, but at some point, my business manager got a little bit irritated because there was no Medicare reimbursement, but now there is. And in particular for rare cancers, it is very important, I think, to at least have sometimes both a local oncologist and someone else who sees large volumes of a rare cancer. So yeah, we do a lot of telehealth. We're working on now, so the patients can have their scans close by, and the scan results can be sent, and there can be a telehealth consultation. There's no need to come in here to Sydney if you don't live here. And that's we're doing that a lot now. So at least a third of my consultations are telehealth, and then we're working on telehealth trials. So there are some models for telehealth trials. We're at the moment working on a model where some pills can be given by the local GP or even local oncologist, and the intravenous can be given locally, but the trial hub is in Sydney. So we involve the GPs if necessary in helping with the trial to make sure that the physical exam is normal, but the patient is sort of managed in a sort of outreach model. So we're really trying to get trials out to rural and regional Australia by using different models to do that, and certainly that's been accelerated somewhat in this era of COVID.
Kate, what's your experience with assisting people out in the bush?
I don't have any experience in that, I'm afraid. But yeah, as I say, I'm in Sydney, but even being able to do the telehealth for me has been really helpful. If it's to, just pick up results or have a conversation, it saves, half a day out of an office or something like that to have those conversations. So I can imagine how valuable they are for regional patients.
And certainly, I must add, as a GP, all the states in Australia certainly have patient travel assistance schemes, which will help with travel and accommodation when you're off accessing treatment. Which, obviously, you do need to go down to a major centre when you're having plaque therapy or radiotherapy. Just reminding people that they can put up questions on the chat line. I suppose another issue that often pops up is, the surveillance and MRIs and abdominal MRIs for the liver are certainly not Medicare rebatable. So that's often an issue of expense for patients. Anthony, do you think we'll ever see a time where we can harass the government to get Medicare rebates for abdominal MRIs?
So I'm not optimistic, but what I tell my patients and what I talked about in some of the earlier talks is that the PET's reimbursed as an ultrasound. So if you can't have an MRI, I get the patients to have PET scans and ultrasounds. So they're covering all their bases. And generally speaking, you either have one very good test or two good tests, and that's the same as having one very good test if you want to catch these things earlier. So I don't think that there's a meaningful difference between having a Medicare reimbursed PET scan and a Medicare reimbursed ultrasound of your liver compared to having an MRI of your liver in reality. And I think that they would be both acceptable strategies. Even the Nccn Guidelines actually say that it doesn't actually matter. They don't give a definitive best test in the international guidelines. They say these are the options. And so I think that to cover your bases with a PET scan and a ultrasound, and you probably need the ultrasound as well as the PET scan, because the PET scan, some of the uveal melanomas are not as hot and don't sort of register, so you need two tests, and so they complementary. But the MRI is quite high definition. So I think using a combined strategy versus a single test is perfectly acceptable. But I have that conversation frequently, Ian, with my patients, saying, look, we're a little bit stuck. This is the situation with the liver MRI. And it does vary from city to city. I find that every now and then I find someone says, I found a practice and they'll do it, that they will do the MRI at minimal cost of the liver for me. because I'm a cancer patient. Another patient say, look, I rang 4 practices and all of them charge $400 to $500. So it's seemingly somewhat hit and miss.
Thanks for that. I must admit, I've had one, and I've got, as you might imagine, I've got a reasonably good relationship with my local radiology provider, and that cost me, I think, in the high 300s. So that's probably gives a reflection of what the basement price is in Australia. Well, I'd like to think it would anyway. I've got a question from Laura Hudson, and it's probably directed more to you, Anthony. Does Australia have a standardised follow-up protocol? If so, is this available?
So I tend to follow the NCCN guidelines. That document is available publicly. In fact, I even think that Susan put it up on the Facebook group webpage at some point. If not, we can certainly arrange that. And you can just Google NCCN uveal melanoma follow-up. And I showed it in my talk, but basically it stratifies patients into 3 categories: low risk, intermediate risk, and high risk. And it is sort of, generally speaking, the frequency of the scans and the duration of the scans increases, you can imagine, from low risk to high risk, with the greatest emphasis being on scans in the first 5 years. So I'm happy, Laura, if you want to see that document, you can. I think you have to register, or I can send you a copy from myself, or Susan can put it up on the Facebook webpage. But it's a massive document that covers all the aspects of uveal melanoma for guidelines for the US, because it's something the US use for reimbursement and insurance companies use for reimbursement. So they try and make it as comprehensive as possible. And within that document, there's a nice table about the follow-up. There are Australian uveal melanoma guidelines. Those guidelines aren't specifically as clear on the follow-up as the NCCN, but at least the NCCN is a starting point. And even at international meetings, there's no consensus as to even what is a high-risk melanoma, because someone's got for example, someone has a large tumor. That large tumor looks like it's got benign genetics. Well, that's a controversial area. So there's limited consensus, but at least there is a document, which is the NCCN guidelines, and I'm happy to help you see that. And the guidelines also cover New Zealand. The NCCN is a panel of experts that got together and they said this is what we think is best. So they imply it's a global guideline system, and I use that as a guide to patients. Patients like to have a piece of paper that says this is what international experts recommend, and I often show that to them during the consultation.
Thanks very much, Anthony. And I suppose that's one of the hassles about having a rare disease. There's never the numbers to actually prove which particular path to go down, particularly as not all melanomas are the same. They've all got slightly different tweaks to them as far as the genetics and as far as the size goes. Just looking and seeing if there's any. Oh, good. Lauren's actually posted that link up on the chat box, so that's fantastic. Thanks very much, Lauren. Sorry, Kate, you were saying?
Well, just one of the things I said in my talk was about, not necessarily about the protocol, but it was about just the information that I needed to know as a patient who, recently diagnosed or being told you're having a enucleation. Basic stuff, how long will this take? When can I drive? Who's this Facebook group? All that kind of thing. It all kind of had to be found, it felt like. Whereas, once I found Susan, obviously she's the font of all knowledge, but it didn't seem like there exists a kind of a patient guide, if you like, in Australia. I wonder if there's one in one of the other countries that we could use as a basis.
I think there's a variety of them around the world. Please go ahead, Anthony.
I do agree with Kate. There's not much on the practicalities. There's not much on the practicalities of these questions. It's sort of like these patient guidebooks which are around, and I think there's one coming from AOMA, and there's one from the US, and there's one of the Melanoma Network of Canada, which they all usually concentrate on the disease. But I certainly agree there's not much out there in terms of the practicalities of how to deal with the disease and the implications for lifestyle factors and quality of life. And as you mentioned in your talk, dealing with your kids. So we are, and I think this is a project for next year, hoping to get a national nurse that will be available for anyone around the country, that will have be a point of contact through a 1-800 number or a Zoom, where the nurse can sort of run through some of those issues and work with the patient advocacy groups to say, look, this is what other patients have asked for, and here's some information which you may not even think you need to know yet, but it's useful. So we're working on some funding to get a national nurse to make that happen, and that hopefully will be an announcement in the not too distant future, and it will certainly loop in everyone on this forum to work out what we need to do.
Fantastic.
And often, the diagnosis of cancer is a very hard time for any and every patient and their families and those around as well. And it's often really hard to actually take all that information in. And that's why, brochures and patient guides are really so useful, because it's something they can take away and look at afterwards. And I see that Lauren, again, has put up the US Ocular Melanoma Patient Guide, which certainly is a good resource, but you've got to sort of realise that it's designed for North American audiences as well, but certainly a whole lot of the basic facts are there. And as Laura has just said, a national nurse does sound amazing, and that would be really quite useful. Facebook groups are also quite good as well. Patients that have been through the journey before, I certainly have found extremely useful on my own progress, and then being able to share information as well.
Yeah.
Happy to take further questions. And as Catherine points out, knowing what it means on a functional level about driving, continuing to work. I mean, one of the things that many of us these days, following treatment, struggle with: working online, working with screens, doing fine work, and getting ideas from those who have gone before as to how long it actually takes to get back to being able to sit in front of a screen for significant periods of time. It eventually does happen for most of us, but of course, sometimes you do get long-term side effects with your vision, and working with your optometrist and other health professionals often is quite useful.
Mm. Yeah, because as you say, everyone's different. When I was trying to find out, the driver particularly is not being able to drive is, first world problem, but it's much harder to get around. You can't get the kids to school and all that kind of thing. And nobody really seemed to know. Some people went back and drove a week later because they had to. Some people said it was illegal for 3 months. And so that kind of thing would be great to centralise somewhere to help people with.
I'm unsure about New Zealand. I'm trying to dredge the driver medical standards from my brain, but I think loss of vision in one eye, forgive me if I'm wrong, it might be something like 6 weeks, but I will look it up and put it up on the Australian Ocular Melanoma side of Susan's, if it's not already up there. Okay. It does take a while to adapt, and the licensing authorities and insurers are very strict about it.
Yeah.
it's sort of getting to the very end of the conference, and it doesn't look like we've got any more questions. A question here for Kate: were you able to find the support you needed from others who had enucleation? What could be improved in that area for other patients?
I was able to find that out, but only after I found Susan and the Facebook group. So I think Professor Joshua mentioned her, but that was a few weeks after I'd had the diagnosis. Sorry, Ian, we can hear your keyboard tapping. So we, I did, once I got on the Facebook group, found amazing people who had been through similar things. Before that, I was trying to order books from America and all sorts to find out what was happening. But also it's a good case of seeing all the different types. So, some people were handling it brilliantly, some people weren't so much. People had, different reactions to it at different times. So it's just good to know that no matter what you're going through, there's somebody else there that's been through a similar thing. But I think, as we were saying, and I spoke to Susan about this, and I think she spoke to Professor Joshua about it, is just creating, we already started talking about creating just one guide, an Australian version, if you like, with all those practical questions in it, as well as the medical questions and answers. So it's amazing that that's happening, and there's a nurse and potential funding. That would be amazing, I think.
Absolutely. We're looking forward on that. And Anthony's posed the question, if anyone has any suggestions for the next AOMA national meeting or next year's Cure OM meeting. I think having this virtual conference has been excellent. It's allowed probably a wider range of people to attend, obviously, and also hearing it very much from an international perspective, both for patients, carers, and clinicians. I think has been fantastic. But whether we were planning to go to Brisbane this year, I don't know whether it's going to be Brisbane next year or whether it's going to be virtual. Certainly, anyone internationally is quite welcome to come to Australia, providing our borders are open. If not, well, maybe we should organise streaming services as well. I think that would be excellent. And certainly, I'm aware of and I've been to American Cure OM events, and often they've been streamed over the last few years. Maybe we should have a poll set up later on about where people would like it to be.
Fiji's good.
somewhere tropical.
Yeah.
With sunglasses. Lots of heavily protective sunglasses.
Yeah.
Yeah, we were thinking about returning to Brisbane, but having a blended format. So there would be one hall, but that would be broadcast to people that couldn't make it to Brisbane, because I think obviously people are going to have other commitments. And one of the problems at the first AOMA meeting in 2019, although it was very well attended, was that not everyone could come who wanted to come. So I think that what we'll do for next year's meeting is that Professor Glasson has agreed to be the chair of the meeting, and we will set up the program so that we'll broadcast it from Brisbane. And so people in Brisbane can go ahead and join the meeting in person, but everyone else could be online, including the Americans.
Do we have to? Oh, I suppose we should, shouldn't we? Yes. No, I think that would be great, because the more knowledge that's shared about this, I think it's very much the better for all of us, and that includes the clinicians and it includes the patients and their carers as well. All of us would like certainly as much information as possible on which we can base our decisions, and again, that's from a clinician and from a patient perspective.
Mm.
So a few little replies coming in, again supporting that concept for Brisbane with a virtual format to encourage more inclusive participation. Cool.
Yeah.
Well, it looks like our time is almost up, unless someone wants to pose a last minute question. Lauren, our organiser, is saying that it's been such a wonderful thing today, and she's thanking all of us for allowing the US and every other part of the world to be a part of it. And Laura's also commenting that internationally we're on the cusp of exciting advancements with treatments for ocular melanoma, and certainly listening to the proceedings of the previous few days, I tend to agree with that. There's a whole lot of exciting and new innovations as well that are happening, and hopefully a lot more news will come out in 2021. I guess it's up to me to thank everyone that's participated, not only today around Australia, Anthony, for all your hard work, and Susan Vine as well, the team from America, Lauren, Leanna, and all the people on Excel events, and the rest of the panel, Kate, and unfortunately the others who couldn't quite connect. That's Susan and Aletta. Sorry you're here, but I can see you both on the chat session. So thanks very much, and I think it's my job to say goodbye, and hope to see everyone next year.
Thanks, Ian. Thanks, Professor Joshua.
Bye, guys.
Thanks, everyone. Bye.